Hey guys, it's Kathleen talking to you a little bit about what I didn't actually have the chance to go over in class. AEDs are considered for, it, first of all, the name is automatic external defibrillators. They're for sudden cardiac arrest, is one of the most, what should I say, they're for people that arrest and suddenly collapse. And those situations are pretty stressful. Nurses are most of them are the first responders, if you will. Cardiac arrest, again, this is the 2011, is reversible in most victims if it's treated within a few minutes, and that's from the American Heart Association. The goal is to decrease the time between cardiac arrest and defibrillation. New evidence is showing CPR, but I kept this because in the hospital what you're going to see is if we have the defibrillator there and we can go ahead and defibrillate, we'll go ahead and defibrillate. But according to test questions, it's CPR first. But in the hospital, you'll see that we're going to try to shock them as soon as possible. Oops. Sorry, guys. Doing all sorts of stuff to annoy myself and everyone else. So AED are defibrillators that automatically detect VFib or VTAC, and these are shockable rhythms. It does not require critical care training or experience. It is required for as you get certified. So you'll be getting the defibrillator or the AED. You're getting someone to get the AED. It is not necessary for an AED to identify the rhythm. If they're not able to shock the rhythm, if they say it's a non-shockable rhythm, that means the patient either has their own electrical conduction rhythm going on that doesn't require shock, or they're asystole, or they have a rhythm that, or they have a rhythm that doesn't require, it's not VFib or VTAC. So basically, the nurses simply attach the electrodes to a person who is unresponsive and is not breathing and pulseless. It automatically charges and signals that the defibrillation is indicated. AEDs have shown powerful evidence that it decreases the time to first defibrillation, which is what we want to do. An AED may be a small standalone device weighing a few pounds, or a module that's incorporated into the conventional monitored defibrillator. An AED can be semi-automatic, which is shock advisory, or automatic. AEDs are safer than conventional defibrillators because they won't deliver a shock if the electrode pads are improperly placed. AEDs deliver high voltage shocks. The operator needs to be certain all personnel are clear of the patient. I'm clear, you're clear, we're all clear prior to hitting the button to deliver shock. So first priority is early defibrillation. Really, for the new guidelines, it's first CPR, but in the hospital, you're going to see defibrillation. So for the exam questions, it's going to be CPR, which are chest compressions, and then defibrillation. An early automated external defibrillation should take priority over CPR. This is really what you're going to see in the hospital. They'll do CPR for maybe a couple while we're getting the pads ready, but for the most part, if we witness a cardiac arrest, we're going to go ahead and shock them very quickly. The most common initial rhythm in cardiac arrest is VFib. Treatment for VFib, the only effective treatment for VFib is defibrillation. There is no pulse, there is no cardiac output with this rhythm. Defibrillation terminates the chaotic activity, allowing an organized rhythm to take over. For each minute defibrillation is delayed, there's a steady decline in the probability of survival. Non-shockable rhythms are PEA, that's the pulseless electrical activity, meaning they have a rhythm. It's not, they just have no cardiac output. So the electrical conduction system has a rhythm, meaning the AED detects there's a rhythm, so no shock is advised. Asystole is a flat line. Shocking a flat line is not going to help. There is no electrical activity. Pacemakers, second degree AV block, symptomatic bradycardia, SA node dysfunction, third degree heart block, asystole, and congestive heart failure, all reasons for patients requiring a pacemaker. With second degree AV block, patients can become type 2, become symptomatic, and oftentimes can go into complete heart block that requires a pacemaker. SA node dysfunction, meaning the SA node isn't firing and they're at risk for sinus arrest, whereas third degree heart block is complete heart block, asystole is flatline, patient is dead. And then congestive heart failure, you can have dual chamber pacing, which actually paces the atria and allows for better cardiac output. And here we have, when I talked, well, I really didn't talk in the review sessions. I talked about these are pacemaker leads that go either into your right atrium or right ventricle or both. And this is the actual pacemaker that's implanted in the chest wall. And oftentimes you'll see patients with a well-healed below the clavicle surgical incision that you want to ask yourself, is this a pacemaker or is this an AICD? You can see on this chest x-ray that they have no pneumothorax, and here's the outline of the heart, and you can actually see the pacemaker implanted. Kind of cool. And the wires to the heart and the pacemaker leads. It's pretty cool. Pacemakers have been around since 1960. It's kind of cool, huh? And there's very different modes. What they found was it was necessary to standardize the language of pacing, and that led to the development of a 5-letter classification code that universally all providers would be able to know what each pacemaker, what each code means. I've had patients that have had pacemakers that were implanted in Italy. And that's why it's important to have universal codes. The 5-letter classification code, the first letter refers to the heart chamber that the device is pacing in. It can be either 0, none, A, atria, V, ventricle, or D, dual. So the first letter stands for where the actual wire is in the heart, where the chamber that the device is pacing in. The second letter indicates which chamber electrical impulses the unit is capable of sensing, such as the above pacing codes. Where is it sensing? Most likely it's going to be, if it's dual both atria and ventricle, then it's going to sense in both atria and ventricle. Third letter refers to the device's response to the impulses received from the myocardium. So is there a no response? Is there a triggered response? Is there an inhibitory response? Or there's dual, both inhibitory or a triggered response? The fourth letter describes the pacemaker programmability, which is it's really the pacemaker's ability to respond to changes in respiration, physical activity, or other parameters that affect cardiac output. So is it a simple program, multiple programs, or a pacing rate, or an R, a pacing rate that can respond to numerous parameters? That's the fourth letter. The fifth letter applies to pacemakers' design. Is it designed to interrupt tachycardia? Designations can be 0 for no response or P for anti-tachycardic pacing, meaning they override that foci that is causing the heart to pace really, really fast. And that's the ectopic irritable foci that's taking over a very tachycardic response. The anti-tachycardic pacing overrides that in the hopes to stop the tachycardia. That's what a lot of AICD has. They can have this, as well as a shock mode, meaning they shock patients, and they can have D, both capable of pacing and shocking. So an example of a case study, you have a patient with a DDD. D means the wire is both in the atrium ventricle and it's pacing both in the atria and ventricle. D is which chamber the electrical unit is capable of sensing. That's the second. The third is the device's response to the impulses received from the myocardium. They're both inhibitory and triggered response. So we talked about like why that is important. Now remember, some patients are not in sinus arrest or in bradycardia all the time. So they only need that pacemaker to work when they're symptomatic. So the pacemaker will inhibit, meaning it won't allow the pacemaker to work. It will inhibit the pacemaker from working if it senses the patient's own beat is above the set rate. So for example, if I had a pacemaker and my pacemaker was set at 60 and the electrodes with both in my atria and ventricles are sensing that my heart rate's 64, then it's going to inhibit the pacemaker from working and let my heart beat on its own. So what you'll see on a rhythm strip is my own native rhythm. A pacemaker rhythm, where you want to look at your book, is a spike and then a capture. So you see the spike sensing that the heart rate is below the set rate, and then you want to see capture right after, which would be a wide bizarre QRS. You want to look at your book on that because it has it right in the chapter. Care of the patient after insertion of a pacemaker. You want to you want to make sure that after they implant the pacemaker, you want to make sure that you go into the chart and identify the type of pacemaker, the type of codes, and why the pacemaker is being placed based on the medical reason, which you probably already should know before they go down. But if you don't and you're just getting a report, these are important things when you're getting a report from the recovery room. You know what their rhythm is before, what their rhythm is after. Is the pacemaker working? There's a pressure dressing over in the incision site located right below the clavicle. Before they used to suture the incision, and now they dermabond it where they glue it, or it depends. Some providers might still suture. It's just a lot quicker to dermabond. You want to have the affected arm, the side that the pacemaker is placed, in a sling, not because their arm is sore or fracture or anything, or they're injured. It's just basically a simple reminder not to extend that arm overhead, because you really want that pacemaker to get settled in and not dislodge. Usually patients get out of bed after the procedure within the first 4 hours. Instruct patient not to sleep on the affected side. And an EKG will be done when they come back up to the floor with the magnet over the pacemaker, which basically you'll get an EKG with a magnet and an EKG without the magnet. This is really important to understand. So the EKG that will be done with the magnet over the pacemaker turns off the impulse sensing device. It turns off the impulse sensing device of the pacemaker. This is to check to make sure the pacemaker is working at its preset rate rather than responding to the patient's natural rhythm. So let me just say that again. When you have post-pacemaker, you will be getting 2 EKGs done, one with the magnet and one without the magnet. With the magnet, it turns off the impulse sensing device. This is to check to make sure the pacemaker is working as its preset rate. This is to check that the cardiologist who put in all the right settings and it's working the way it does. It's set. That means when you look at the EKG, you're going to see the pacemaker working 100%. It's not sensing the patient's own beat at all. It shuts off that sensing ability and just paces. What you should see is a pacemaker spike with each capture for each pacemaker impulse. Really important concept. So, cardiac tamponade. Now, this pacemaker article is really great. It's very simple. I love it. It's old, but it's very relevant. I haven't found a better article. Same with cardiac tamponade. Again, make sure you read this article very carefully. So with cardiac tamponade, if you have to read this article, if you don't read this article, you kind of put yourself up an avenue that's not good. With cardiac tamponade, tamponade can occur with any, not just a motor vehicle accident where the body gets thrown into the steering wheel, or you have a frontal impact to the myocardium. This can occur for patients getting central lines, pacemaker placed, chest tubes, all sorts of procedures that occur in the mediastinum. Patients are at risk for tamponade. And basically, if you can draw the heart in your own picture, what happens is that fluid collects. It can be fluid or it can be blood. Collects in the pericardium where there should not be any fluid or blood, just a little bit. So a very small amount of blood or fluid in the pericardium is not normal. Patients with chronic heart failure can, over time, develop up to a liter of fluid that can cause, a tamponade. But someone who gets in a car accident and gets tamponade, that amount of fluid might be 20 mLs. So just know that there can be a big difference, and the article does speak of that. The fluid collects in the pericardium, and basically it begins to squeeze the heart, and it targets the thin-walled chambers of the right heart first. So if you think about, you have a sac over your heart that surrounds the atria and the ventricles from both the right and the left. When it's like a physics law, that fluid presses on the right side of the heart first, and when it does press on that right side of the outer side of the heart, then you lose the ability to fill. It takes away that space in the heart when fluid accumulates that shouldn't be there. So it restricts the ability to fill. You get increased right atrial pressure, and you get CVP as a compensatory attempt to maintain the filling, because as the heart is filling with fluid in the sac around the heart, it's taking away the space in the right ventricle, and it's moving from the right atrium, right ventricle, all the way over and can bulge into the left atrium. So it starts in the right, and then as it the tamponade progresses, worsen and worsen and worsen, it can bulge into the left ventricle, decreasing, worsening cardiac output. If CVP isn't being monitored, this compensatory response may not become evident until venous pressure rises significantly. And JVD develops in JVD, you should have learned in health assessment, which is that jugular venous distension where you have oscillation in the side of the neck, which is a sign of fluid overload. But it's used as a compensatory mechanism. CVP also helps the heart fill at the expense of the left, causing a drop in cardiac output. As a compensatory mechanism, tachycardia kicks in to maintain blood pressure. So further compression limits the size of the heart chambers so that they're no longer able to dilate, and stroke volume continues to fall, and the pressure in the ventricles rise sharply during diastolic filling, and pulse pressure begins to narrow. So the heart loses its space in the atria and the ventricles due to the pericardium filling up with fluid. As tachycardia fails to maintain blood pressure, SVR rises to assist pulse pressure. What patients present with is paradoxical pulse, where you get a greater than normal drop in blood pressure, systolic blood pressure during inspiration. So the difference between these two levels is normally no greater than 3 to 4. So if you're taking the blood pressure, you look at the inspiration and the systolic blood pressure drops 20 during inspiration, you know that you have a paradoxical pulse, and that has to do with decreased interthoracic pressure. Pulsus paradoxus is an exaggeration of normal drop in blood pressure that occurs on inspiration as the interthoracic pressure decreases. And pulsus paradoxus is a hallmark sign of advanced tamponade. I had a patient once that had a nail gun to his right atrium, and this picture reminds me of, and he died of tamponade. So the lower the thoracic pressure allows for a greater forward flow of blood into the right heart. So the article in your book talks about, this is similar to like air being pumped into a manual blood pressure cuff. Fluid collects in the pericardium and begins squeezing the heart. Again, the compression targets the thinner walled chambers of the right heart first, restricting their ability to fill. Right atrial pressure and central venous pressure rise in a compensatory attempt to maintain diastolic filling. Remember, the heart needs to fill in order to get cardiac output. So cardiac tamponade tends to be progressive. There's a Beck's triad, classic characteristics that you need to know, which is hypertension, muffled heart sounds, and severe JVD. These are all late developments, but it's called Beck's triad, which is hypertension, muffled heart sounds, and severe JVD. And what you can do to save lives of patients with cardiac tamponade is a careful history, asking the right questions during report, knowing what to look for, and having a plan of action so you can intervene quickly. Know who's at risk. Patients heart transplant, patients who've had a cardiac cath, patients with coronary artery bypass surgery. Before they sew patient's chest up, they, outside of the epicardium, they sew pacing wires in. And just in case patients are bradycardic, they can hook them up to an external pacemaker and pace them that way. But those wires can be pulled, and when they pull them off of the epicardium, they can cause tamponade, so you have to watch for that. Balloon angioplasty is another procedure that can cause make patients at risk. Pacemaker insertion, central venous catheter placement, also transmyocardial revascularization has to do with laser. A lot of patients with end-stage coronary artery disease that cannot be bypassed, they can laser the channels in the myocardium to help perfusion occur from the coronary arteries. But that also can make them at risk because they're lasering the epicardium. Fine needle biopsies of the chest also make them at risk for cardiac tamponade. Remember, cardiac tamponade tends to be progressive. These are already kind of the Beck's triad: hypertension, muffled heart sounds, severe JVD. These are all late developments. What are the earliest signs of cardiac tamponade? Tachycardia, increased CVP, pulsus paradoxus, which is a drop in systolic blood pressure during inspiration. Narrowing of pulse pressure, the difference between systolic and diastolic, they're actually coming together closer because the pressures are higher because the heart isn't able to fill. So you get that diastolic number coming very close to the systolic number. In pulsus paradoxus, you get a drop in systolic blood pressure because of during inspiration or during increased venous return, you get an increased venous return with decreased interthoracic pressure. But with someone in tamponade, the heart is squeezing, so you get a drop in systolic blood pressure, which is pulsus paradoxus. So the treatment for this is preparing patient for a pericardiocentesis, which is going in with a needle and pulling out the fluid or blood that's causing the tamponade. So most likely we'll be getting a chest x-ray, an EKG, and an echocardiogram. Let's see how big the tamponade is emergently. And most providers now in the ICU do bedside ultrasound, which they can make the diagnosis fairly quickly. We want to get the patient in a semi-Fowler's position. We want to provide O2 and apply EKG leads from a defibrillator. We're going to infiltrate with 1% lidocaine to the area that the provider is going to go in with a needle and in a guided ultrasound and withdraw some of the fluid. We're going to start IV normal saline infusion. So also remember your patient's preload is already reduced, so vasodilators such as nitroglycerin and nitroprusside should not be given. So remember, when your right side of the heart is squeezing with fluid, remember it goes on the thin walled first, it's squeezing from the outside and going towards the septum. All right, so when it does that, and when it starts squeezing towards the septum, then you lose that ability to fill. So the patient's preload is already reduced. So giving them nitroglycerin or nitroprusside is going to cause them to vasodilate and have less preload. So that's why you can't give nitroglycerin and nitroprusside. The physician or the provider, whoever does this, is going to palpate the junction of the xiphoid in the left costal arch and insert a needle below the xiphoid 30 to 45 degrees and gently aspirate. During procedure, you're going to watch for a running EKG for ST segment changes or T wave inversions, which means they could have damaged the myocardium, or if they're having PVCs. And then this is an example of the heart, the xiphoid that is retracted, and then a sub-xiphoid approach. And here's the diaphragm. So here's a fluid-filled pericardial sac. And if you look here, this is the right side, the left side. Remember that you see the fluid that's more on the right side. So it squeezes as the heart is coming in with unoxygenated blood. The tamponade squeezes over, decreasing the amount of blood that's coming from superior vena cava and inferior vena cava. So you want to assemble a 16 or 18 gauge 4 to 6 over the catheter needle, a 3-way stopcock, a 50 cc syringe, tape, local anesthetic like 1% lidocaine. You want to cleanse the insertion site, get sterile gowns, masks, and gloves. And again, the tools to determine a tamponade: a chest x-ray, EKG, and echocardiogram. If you suspect tamponade, you want to start oxygen, request stat EKG and echo. You want to get blood bank on board and a type and screen. And you want to check a potassium level, because we know that an irritable myocardium, like a low K, can cause the patient far increased risk of dysrhythmias. And now you're going to go in with a needle to the myocardium, epicardium. That's going to cause them to be even more at risk for fatal arrhythmias. All right, I said a bunch. So again, the last thing I would say is that when you get the patient needs to be in you need to, as a nurse, prepare the patient for the procedure in a semi-Fowler's position, and basically that lowers the diaphragm and the abdominal organs, allowing blood to pool in the apex of the heart. And again, we want to provide oxygen and apply EKG leads from the defibrillator. And that's it. Any questions, just let me know. Shoot me an email.